Welcome, everyone, to today's program. I am Laura Dierda, Editor-in-Chief of Becker's ASC Review. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to turn the floor over to John Bartos, President and Chief Executive Officer of CollectRx, to kick off today's webinar.
Thank you, Laura. Appreciate the introduction. Hello, everyone. My name is John Bartos, and I'm CEO of CollectRx. And despite our name, CollectRx is not a collections agency, not a billing company, and has nothing to do with the pharmaceutical industry. Simply put, what we do here at CollectRx is we help providers get higher reimbursements on out-of-network bills. And we do this not as consultants, but as experts in negotiating reimbursements one case at a time. Think of us as your prescription for higher out-of-network payments. During today's presentation, I'll be talking about the hidden opportunity to significantly increase profits by maximizing your out-of-network reimbursements. Specifically, I'll be talking about the out-of-network opportunity, why it's important, the tactics used by insurance companies to reduce your reimbursements on these bills, how you can combat these tactics to maximize your out-of-network reimbursements, and finally, discuss the option of outsourcing. So let's face it, as providers survey the landscape today, candidly, there aren't many opportunities to improve reimbursement rates. Your in-network contracts are what they are. There's limited, if any, opportunity to increase those rates. And with respect to your Medicare and Medicaid reimbursement rates, there's literally no opportunity to change those rates. But by leveraging out-of-network reimbursements, it represents a last great opportunity for many providers to bring more dollars in the door to improve the bottom line. Next slide, please. Before discussing the opportunity to increase revenue significantly through higher out-of-network reimbursements, I'll spend a couple of minutes explaining who we are and our experience in this area. We have deep, specific expertise in out-of-network reimbursements accompanied by sophisticated data and analytics that help us get higher reimbursements for our customers on out-of-network bills. Next slide, please. CollectRx is the only company in the country that's focused solely on helping providers get higher reimbursements on out-of-network bills. Because of our results, we've grown to more than 1,300 customers throughout the country since we opened our doors in 2006. We work with many of the nation's largest ASC management companies, freestanding surgeries, and surgical hospitals. And in addition, we work with large health systems, teaching hospitals, community hospitals, and physician practices. Next slide, please. A big reason these folks turn to us is because of our team. We have former hospital CEOs and CFOs, we have physicians and in-house and outside legal experts on our team, many of whom have over 15 years experience dealing specifically with out-of-network bills. Our team has held senior management positions with the insurance companies and vendors like Aetna, United, Multiplan, and Viant. CollectRx was founded by Dr. Don Greenberg, a physician with a Wharton MBA, who started a company called About Health in the early 1990s. About Health was the first to work on behalf of the insurance industry, showing them ways to reduce their reimbursements to providers for out-of-network bills. About Health customers included many of the nation's largest payers. In 1999, Dr. Greenberg sold About Health to a company called Concentra, which was his largest competitor. Concentra then changed its name to Viant and was eventually acquired by Multiplan. He left the business in 2000 and started CollectRx 6 years later in 2006 to work on these out-of-network issues on behalf of providers. Over the years, we built a team with deep experience in understanding what the payers, negotiation vendors, and repricing vendors do to lower your out-of-network reimbursements. This expertise comes from having worked for these organizations knowing the soft spots, so to speak, to push to get higher reimbursements on out-of-network bills. Next slide, please. Another reason for our success is what we call our CRIXIS Business Intelligence Engine. CRIXIS, C-R-X-I-S, stands for CollectRx Information System, and it's the data and analytics tool that we've created to counter the payer efforts to reduce payments on out-of-network bills. It allows us to do a variety of things like analyze actual policies from insurance companies throughout the country to determine what's reasonable and customary. It also provides us with an incredible amount of comparable data because we aggregate the data and results from the hundreds of customers that we service. And we use data and analytics to compare our determination of reasonable and customary with the payers. And in many instances, we're able to identify holes in their data and convince the payer to increase their payments. Our database also captures the business intelligence about the tendencies and trends of the people on the insurance company side. Our experienced team knows who to speak with at each of these companies, and we have the ability to go to senior personnel at the insurance company who oftentimes are the only ones with the authority to approve higher payments to providers. And our engine combines all of this data to suggest best case results. Next slide, please. So in summary, how do we do it? We take your out-of-network bill, run it through our CRIXIS Business Intelligence Engine, apply our expertise in handling these cases, and get the most money we can for our customers. Next slide, please. So with that as background, let me turn to the opportunity to generate more revenue through higher out-of-network reimbursements. Now, I go to a lot of conferences, I read a lot of industry publications, and as I read and hear what some people say about out-of-network reimbursements, I am continually amazed at how often people either have it half right or not right at all. And I'm also surprised that providers don't do more to take advantage of the opportunities with out-of-network reimbursements to bring more dollars in the door. Next slide, please. Okay, so let's start with the basics. Out-of-network reimbursements are higher and frequently much higher than in-network reimbursements. Not always, not in every geography with every payer, but generally speaking, out-of-network reimbursements are higher. The key is making sure you're in a position to maximize this opportunity. Next slide, please. Quite often, we're asked by providers how they should approach their out-of-network strategy and how much of their revenue should be from out-of-network patients. While you might think we'd recommend that you go 100% out-of-network, that's actually not the case. Our view, and the view of many of the hundreds of ASCs with whom we work, is that a hybrid out-of-network, in-network strategy puts surgery centers in the best position to maximize revenue. In other words, we recommend a strategy whereby a surgery center goes in-network with some payers and out-of-network with other payers. The decision should be based on factors such as geography, payer mix, employer mix, and the in-network reimbursement rates. Next slide, please. In terms of quantifying the opportunity to maximize out-of-network reimbursements, let's take a look at the impact that we have on surgery centers as to what can be done. The typical surgery center utilizing our services, after taking our fees into account, we generate approximately $128,000 per year, or about $11,000 a month, in additional out-of-network payments from the insurance companies. This is an average, of course. Some are lower, some are higher. Next slide, please. Here's another data point that shows that the out-of-network opportunity is not diminishing. This is data from one of our long-term clients for whom we do appeals. This shows that the amount of additional payments we've obtained for this client on appeals remains virtually the same for the past 4 years. Next slide, please. And this opportunity exists if only a small amount of your business is out-of-network. So for example, I know this is a lot of information on this slide, but let me sort of work through it here. Suppose your facility generates 15% of its revenue from out-of-network patients. If an ASC with $5 million of net revenue generates 15% of that revenue from out-of-network bills, and the allowable amount is increased by 1/3, meaning that the payer increases the reasonable and customary payment amount by 33%, that will result in a $247,000 incremental reimbursement in profit. So what does this increase in incremental reimbursements and profit mean from a revenue perspective? In other words, how much additional revenue would you have to generate at your current margins to equal the out-of-network opportunity described on this slide? Well, suppose you're operating at 20% margins. To generate an additional $247,000 of profit at those current margins, you would have to add approximately $1.2 million in revenue. I think everyone would agree that an additional $1.2 million in revenue would be a good thing. Now, let's suppose that your current volume of out-of-network revenue is 50% instead of 15%. The improvement in your out-of-network results equates to more than a $4 million increase in revenue, again at 20% margins. Or let's say your current volume of out-of-network revenue is 5% instead of 15%. The improvement in your out-of-network results equates to more than a $400,000 increase of revenue at 20% margins. So let me put it a different way. Suppose you were in a contract with a payer who comprised a small portion of your business. If they offered you a 33% increase in your reimbursement rates, you'd be very happy, right? Well, that's the opportunity here. Next slide, please. So now that we've focused a bit on the financial opportunity, let's discuss the current out-of-network environment, pardon me, and the future of out-of-network in that environment. Our view is that out-of-network is and will remain important for the reasons set forth below. First of all, despite the predictions I sometimes hear and the efforts that payers have made to reduce out-of-network reimbursements, today there are $60 billion of out-of-network claims each year, which has remained relatively the same for the past several years. In other words, it's quite a large market today. Next slide, please. A second reason that out-of-network will continue to be an important piece of the market is the sustained growth in PPO enrollment. Next slide, please. Most out-of-network bills come from PPO members, and PPO enrollment has more than doubled as HMOs have declined. Here you can see that it's gone from 26% in 1993 to 71% in 2013, and statistics show that 10 to 20% of PPO members will have an out-of-network experience each year. Next slide, please. The third reason is the Affordable Care Act and the provisions in the ACA that promote the growth of out-of-network patients. Next slide, please. It's our view that with the implementation of the ACA, the number of insureds with out-of-network benefits will rise, and let me talk about the two reasons why. As of mid-July, the number of individuals who had picked a health insurance plan from the ACA marketplace was over 10 million. While the policies will vary, and not all plans are necessarily friendly towards out-of-network care, nevertheless, a portion of those that sign up will have out-of-network benefits. And given the fact that virtually all of the 10 million plus people who signed up were not previously insured, by simple math, that will increase the number of insured seeking out-of-network care. Next slide, please. Yet not only will we see an increase in patients with out-of-network benefits for this reason, we will also see an increase in out-of-network cases as narrow networks accelerate under the ACA. So what is a narrow network? A narrow network is a health insurance plan that places severe restrictions on providers available to their insureds. While narrow networks were already on the rise prior to the adoption of the ACA has accelerated their growth. Narrow networks place limits on insureds by creating higher patient responsibility for care that's provided outside the network. However, for the most part, they don't prevent patients from seeing those providers, and as such, the narrow networks will result in there being more out-of-network care. Again, by simple definition, you'll have fewer providers that are in-network, making it even more important to be able to handle out-of-network issues. Next slide, please. Okay. So at times I hear people argue that the adoption of so-called limited benefit policies means that out-of-network will be negatively impacted going forward. Now, a limited benefit policy is one that limits out-of-network benefits, and frequently these policies tie benefits to a percentage of Medicare. It could be 100% of Medicare, it could be 150% of Medicare, or somewhere in between. You may have heard of the United Healthcare MNRP policy or the Cigna MRC2 policy. Those are a couple of examples of those types of limited benefit policies. But based on what we've seen, We believe the impact of these policies on the out-of-network opportunity has been greatly overstated for the reasons set forth on the next slide. Next slide, please. First, in looking at our cases in Crixus, the majority of United Healthcare and Cigna cases that we handle at CollectRx are not MNRP or MRC policies. Rather, the majority of bills involve standard, reasonable, and customary reimbursements. Second, we went back and looked at our own data regarding MNRP and MRC cases. As the data above shows, the rise in such policies occurred, frankly, 3 years ago, between 2012 and 2013. In 2013, 14, and 15, the percentage of cases that involve these policies has remained virtually identical. In other words, this should show that the impact has already occurred, it's now stabilized, and it's not getting worse. Finally, even when they're used at CollectRx, we've been relatively successful in resolving bills involving limited benefit policies that our customers bring to us. Next slide, please. But the ultimate and by far the most important reason we believe out-of-network is not going away is that people want to have out-of-network benefits, people are willing to pay for out-of-network benefits, and at the end of the day, payers will have no choice but to sell policies that have out-of-network benefits. And while the prevalence of opportunities to improve out-of-network reimbursements may vary by geography and individual factors, it's clear that it's not going anywhere and that it's here to stay. Next slide, please. So now let's move on to how you can maximize out-of-network reimbursements and increase overall revenue. To do so, I need to explain what the payers are doing to reduce out-of-network reimbursements and show how to respond to those tactics to take advantage of the opportunity. Next slide, please. A bit of history here. Back in the good old days, before 1990, out-of-network bills were paid at full bill charges. Next slide, please. Today, payers are using a variety of tactics which allow them to reimburse providers at between 20 and 50% of bill charges. But if you know what you're doing, you can improve these results dramatically. Next slide, please. There are two main strategies used by the payers to minimize your out-of-network reimbursements. Think of it like an economist might. First, there are the micro-level strategies where bills are minimized on an individual bill-by-bill basis. Second, there's the macro-level strategy where bills are subject to different types of global discount agreements. Next slide, please. So let's discuss the micro-level first. On a bill-by-bill basis, payers will attempt to minimize reimbursements by either negotiating single-case rate agreements at reduced amounts or by repricing bills using a usual and customary reduction. Let me explain both in more detail. Next slide, please. The vendors that work for the insurance companies, companies like Viant and Multiplan, each receive over 10 million out-of-network bills each year. These vendors employ senior professionals with deep expertise in understanding how provider organizations operate. Every time a new bill is received, these vendors use computer algorithms to determine which of two bill reduction tactics will yield the lowest possible payment to the provider. One tactic described here is to negotiate a settlement in exchange for the provider agreeing not to balance bill the patient for the discounted amount. In other words, the insurance company reaches out to negotiate fees after services have been provided, after the patient leaves the facility, but before the insurance company makes a payment. Oftentimes, these are initiated by the vendor faxing a settlement proposal to the provider, often with a short turnaround time for a response. When they choose to negotiate, the vendors do so with vast amounts of data at their disposal, and they use that to reduce out-of-network payments. Next slide, please. The second bill reduction tactic described here is for the vendor for the insurance company to simply reprice the bill down to reasonable and customary, which is typically close to the Medicare rate. So in other words, the insurance company reprices the out-of-network bill down to 50% or less of bill charges based on their determination of what is reasonable and customary, or doesn't pay at all because the claim is denied or unreasonably delayed. From the insurance company's perspective, after the bill is repriced, the insurance company has satisfied its obligation, there's nothing more to be done. Now here at CollectRx, we offer two services to address each of these tactics. The negotiation prepayment service is the one used to respond to the first tactic, where the bill hasn't been paid and the vendor reaches out to negotiate a settlement. The appeal post-payment service is used to respond to the second tactic when the bill has already been paid, and we appeal to try to get more money for our customer on these bills. Next slide, please. Okay. So to understand which approach the insurance company will utilize, it's necessary to understand how out-of-network bills are processed. The process starts with the provider generating an out-of-network bill, which is sent to the insurance company, which is then sent to one of the vendors that we were talking about before. The bill then will either be subject to negotiation or it will be repriced. How that decision is made is the key. So when an insurance company sells to an employer group, the employer group has the ability to dial up or down the out-of-network benefits. There is a basic trade-off here, a trade-off between employee discontent and the payment of premiums. The higher the premiums, the lower the discontent because benefits are better. The lower the premiums, the higher the discontent because benefits are worse. And this holds true for self-insured plans where the issue is the employer laying out the actual claim payments. The dials come in different forms, if you will. First, does the payer negotiate settlements, and if so, at what rates? Second, what's the maximum allowed amount when bills are repriced? Third, if a provider or a patient pushes back, what should the payer do? It can range between what the payers call stand on data, meaning that they don't move at all because they move at all to increase payments on the in making fairly drastic concessions to eliminate patient noise on the other end. This is a spectrum, and employers can choose anywhere they want to be along that range. And the irony of the whole thing is whatever the employer chooses, the vendor or insurance data to support the decision. Next slide, please. The insurance companies outsource the implementation of the bill-by-bill minimization tactics to companies that specialize in helping payers reduce payments to providers, either through negotiation services, repricing services, or both. You may have heard of these companies. We've already mentioned Multiplan and Viant, there's NCN, there's GCS, just a handful of the companies that specialize in helping the payers in this regard. There are now well over 100 companies that assist payers with reducing out-of-network reimbursements to providers through these bill minimization tactics. And it costs providers literally billions of dollars per year. These vendors hire senior professionals who used to work for providers and know a lot about you. Sorry, next slide, please. Their databases track every past negotiation, so when an out-of-network bill is input, a screen pops up with the names, titles, and phone numbers of everyone in your business office. And that screen will say, don't go to Mary, you'll only get a 30% discount. Go to Bill, you'll get a 40% discount. So next slide, please. So that's what the payers are doing. Let me talk about what you can do in response to these tactics and help you increase out-of-network reimbursements. Next slide, please. The first key is time and persistence. Handling out-of-network bills is a time-consuming task that requires persistence. On any given case, you may need to write multiple letters, make multiple phone calls, literally every day. Next slide, please. The second key is focus. Your team might be pulled in many directions, and dealing with out-of-network cases is one of dozens of tasks that your team is juggling on any given day. Having them focus and spend that time on out-of-network reimbursements is a key to success. Next slide, please. Here's a case study from one of our clients utilizing our negotiation prepayment service. Before using us, this client was averaging 74% of bill charges on their settlement negotiations, and like many providers, thought they were doing fine because 74% is greater than their in-network and Medicaid reimbursements. It's not, of course, the right comparison to make. With cases totaling over 1.9 million in bill charges, our average settlement was 90.3% of the charges, or $1.8 million. So by using our negotiation service and the focus, time, and persistence that go along with it, the client increased their out-of-network revenue by more than $140,000. Next slide, please. The third key is having specialized out-of-network expertise that's necessary to be successful on these cases. Next slide, please. Here are examples of the areas of expertise that you need in order to be successful. Next slide, please. So let's start by talking about the explanation of benefits, the EOBs. Do you have the requisite expertise to read and properly understand an EOB? Because by design, EOBs are often difficult to decipher, which, when coupled with the fact that staff can be very busy, means that they're often not read or reacted to correctly. As an example, I've inserted a couple of actual EOBs here that show how confusing they can be. We'll talk about the first one here. Payments of benefits has been made in accordance with the terms of the managed care system. Now, reading this statement might lead one to believe that this was paid at in-network benefits in accordance with the managed care system. In reality, it's saying that the managed care system contains out-of-network bills and that the bills were processed based on these out-of-network benefits. Are you confident that everyone in your business office would come to that conclusion? The second one, charge exceeds fee schedule / maximum allowable or contracted / legislative fee arrangement. This is a catch-all that gives 4 distinct options as to how this bill was processed. Which one would you pick, and how would you proceed to question it? Next slide, please. Okay. So similarly, with respect to the assignment of benefits, do you have a well-drafted AOB? We're not offering legal advice here, but a few of the items you may want to ensure that are included are, does it assign the rights to appeal, expressly assign the rights to appeal, and the right to receive relevant documentation, and then generally assign all of the patient's rights. 2, refers to the provider as the patient's representative. 3, properly references ERISA and a full and fair review of claims. If your AOB is inadequate, it's just another roadblock that the payers can put up to stop you from being reimbursed on your out-of-network bills. Next slide, please. The next is to document all calls. Do you document all calls with the payer, whether it's with respect to benefits, pre-authorization? While sometimes payers will tell you expressly that you cannot depend on what is said on these calls, you're best off ensuring that both parties understand what was said and that the provider has a record of what was said. Next is recording the reference numbers of calls with the insurance companies. Do you record the reference numbers for all payer calls? It's important to record these reference numbers in case there's a dispute later as to what was said. Next slide, please. A 4th key is to obtain the data to prove that the insurance company's payments are inadequate. You need to be able to argue that the insurance company's reimbursement level is inconsistent with your own history and preferably the history of other providers in the community. Next slide, please. The 5th key is understanding payer-side incentives, both from a financial point of view and from the perspective of them keeping their customers happy. Next slide, please. The 6th key is to have a rigorous appeal process for those bills that have been cut due to UCR repricing. Let me show you our process on the next slide. Next slide, please. So we're on the same page, and to make sure we're in sync here, as we discussed before, appeals occur when a payer reprices a bill at a low amount and you're trying to re-engage the payer to make a second payment. From the insurance company's perspective, they're done. They made a determination of what is reasonable and customary, made that payment, and now it's up to you to get them to change their minds. It's a labor-intensive process to appeal an underpayment and obtain a higher payment, and here are the steps in the appeals process at a 50-foot level. Step 1, initial intake. Ensure you have the documentation to handle the claim. Make sure you have the UB, the EOB, the AOB, and any billing and collections notes. Step 2 is payer verification. Contact the payer to verify the patient and bill information and obtain a verbal explanation for the basis of the reductions. Step 3 is the strategy development. Devise the appropriate strategy for that claim. This involves formulating the facts and arguments to be made to the payer. Of course, we use our Crixus business intelligence engine to assist in that process. Step 4 is payer engagement. Engage the payer, present the relevant facts and arguments to the payer. To be successful with appeals, you need to be able to call every day, write letters every day, escalate when necessary, and once you present the full information to the payer internally reconsiders its decision. Typically, several weeks will pass before the payer reaches a decision. And step 5 is the settlement agreement and post-settlement follow-up. Not surprisingly, payers don't always pay on time. They don't always pay in the right amount. So when you are successful getting an additional payment, you need to follow up with the insurance company to make sure that you get paid. Next slide, please. The 7th key is performing audits of your out-of-network activity. Ours is set forth in the following couple of slides. Next slide, please. One of the services we offer our customers is what we call the CRICS's out-of-network audit review service. With minimal staff effort from the provider, we do a methodical review of all out-of-network cases handled by the provider, usually for the last year, to identify accounts with potentially recoverable underpayments, as well as assess their out-of-network performance. Oftentimes, we're able to turn these underpayments into significant revenue by appealing to the insurance company for additional payments on these cases that got lost in the cracks, so to speak. Next slide, please. The process is very simple, starting with running a report of out-of-network activity for the past 12 months. You then analyze the report, focusing on finding cases to appeal and ensuring that your negotiation results are good. If there are cases to appeal, of course, do so. And when we do it for most of our customers, they often end up with found money, plus they ensure that they're operating at a correct level from an out-of-network perspective. Next slide, please. Here's a real-world example that will give you a sense of the revenue that can be generated by appealing these cases and auditing these cases. This is a surgical hospital who'd been a long-standing client of ours, and when we initially suggested an audit, they said no. They'd been referring cases to us for some time, and were sure that they hadn't missed any. But because the effort was minimal, we convinced them to run the report. We ended up opening 150 cases with about $2.9 million in billed charges and initial payments of $691K. These were, again, cases that hadn't been sent to us. We were able to generate over $500,000 in additional revenue for this customer. Next slide, please. Finally, the 8th key is having access to healthcare reimbursement attorneys. This allows you to escalate when necessary in your appeal process. Next slide, please. So those are the keys to maximizing out-of-network reimbursements in the face of the bill reduction tactics used by the payers. How do we compare with these keys? Well, key 1, we have the manpower and the time to do this on a full-time basis. Second, while your team may be pulled in many directions, we're focused solely on increasing reimbursements on out-of-network bills. That's all we do. Key 3, part of our secret sauce is the depth of our knowledge of how out-of-network reimbursements work from an insurance company's perspective. Key 4, we have an incredible amount of comparable data because we're aggregating data and results from the more than 1,300 customers we work with. And we use that data and analytics to compare our determination of reasonable and customary with the insurance companies. And in many cases, we're able to identify holes in their data and convince them to increase their payment. Key 5, we leverage payer and vendor financial and customer incentives to maximize client reimbursements. Key 6, not only do we invest in resources, but we have processes at work, and we understand when to make calls, when to write letters, who to contact, when to escalate, all of those factors that are key to success. Key 7, we have an audit process that we put together to identify opportunities to gain additional revenue and ensure you're handling out-of-network cases appropriately. And then key 8 is healthcare reimbursement attorneys. We have attorneys on staff as well as access to outside attorneys. Next slide, please. So let's move on from the bill-by-bill minimization strategy used by the payers and discuss the second main strategies used by payers to minimize out-of-network payments, the so-called global discount agreements. These include third-party rental network agreements and continuous discount agreements. Next slide, please. So what is a third-party rental network agreement? Third-party rental network agreements are agreements signed not within an individual payer, but with a third party that contracts with a lot of payers. Think about them as middlemen of sort, bringing together payers and providers to participate in contracts that often are not favorable from a provider perspective for a number of reasons we're going to discuss. Moreover, they're often offered to other payers and networks that the provider doesn't even know about, the so-called silent PPO. They sound easy. With one contract, you essentially have a contract with all of the payers that have signed up to this network on the other end. Most providers, however, as we'll talk about in the next few slides, don't understand how detrimental they can be. Next slide, please. So it's important to understand who is the customer with these agreements. And to be clear, it's not the patient, it's not you, the provider, it is the insurance company. Go check out their websites, you'll see it right there. The reason this is important is that they are not there to serve you, but they're there to serve the insurance companies. And they do so as a cost containment initiative for the payers. Think about it. If they're helping payers save money, who is losing money by these arrangements? Next slide, please. So while these agreements may sound attractive because they're easy to implement, these relationships oftentimes have unintended consequences and need to be closely scrutinized. Let's review some of the specific issues that often arise in these agreements. The first here, how do they treat patient steerage? Be clear that there's typically no patient steerage from these rental network agreements. As you know, in the traditional managed care contract situation, you are essentially agreeing to a discount in exchange for the insurance company steering patients to you via a strong, explicit financial incentive for the patient. Think of it like a volume discount situation. You agree to lower reimbursements in exchange for more patients. So there is patient steerage in traditional managed care contracts. In contrast with these rental agreements, however, you're accepting a discount, but typically are not seeing any additional payments. Next, do providers know that they've entered such agreements? Not only do providers have no idea of the breadth of these agreements, many providers don't even know they've entered into them. They were signed years ago by staff no longer at the facility, and the surgery center doesn't even know it. Are the payers required to use a contract? Well, the payers don't have to access the contract. In many instances, they have a number of agreements, and the payer selectively chooses a contract with the most favorable rates. And in fact, sometimes payers will even give cases to their vendors when there's a contract, asking the vendors to negotiate a single case rate agreement at rates that are better than the contract. Next slide, please. Additional items to consider. The reimbursement levels, are they adequate? As we've discussed, out-of-network reimbursements industry-wide are generally higher than contracted reimbursements. How do the reimbursement levels in these contracts compare to what you'd be doing were you to stay out-of-network? An important point here, are the reimbursement levels based on a percentage of billed charges or allowed charges? Sometimes providers don't realize that the reimbursement levels are based on a percentage of allowed charges and not billed charges. This means that the payers take a cut to arrive at the allowed amount, then apply the percentage to that lowered amount. So let's say you have a case with $10,000 in billed charges, and the agreement says that they're reimbursing at 70% of allowed charges. In this case, with $10,000 in billed charges, you would not be getting $7,000, which is 70% of $10,000. Rather, the payer will determine the allowed amount, and let's just say here, hypothetically, $6,000. Then you would get 70% of that $6,000, or $4,200. Providers need to pay close attention to how this term works. Next, are payers properly accessing the networks? Many providers receive payments at very low rates, with payers citing contracts they didn't know existed. If you have a contract with a third-party rental network, ask yourself, do your patients have insurance cards with the logos displayed? Does the contract specify the payer is allowed to access the agreement? Do you know if the payer is part of the network? Does the contract specify the changes in who can access the network must be communicated to you? Is there a provider directory? A lot of times you're really just flying blind as to what the payers can do in terms of accessing the contracts. Next slide, please. Additional items to consider. Are payers implying in-network discounts with out-of-network benefits? Some agreements specify that out-of-network benefits can be applied, while other agreements are silent on the issue. In either situation, payers often apply in-network discounts and higher out-of-network deductibles and copays, sort of double dipping if you think about it. Most providers just assume that the in-network benefit levels are being applied and don't even realize what's happening. Does the agreement provide for multiple procedure reductions and other claim edits? A multiple procedure reduction occurs when a provider performs 2 or more procedures, and rather than reimburse all those procedures at 100%, the payers apply multiple procedure reductions whereby they reimburse the subsequent procedures at lower rates. Does your agreement allow the payer to do so? Next, is there a reference to an administrative handbook? Oftentimes these agreements explicitly incorporate the handbook. In other words, the handbooks are literally part of the contract. So for example, combining this point and the point above concerning multiple procedure reductions and code edits, we've seen situations where the agreement doesn't address multiple procedure reductions, but the handbooks do, therefore making it part of the contract. How many providers actually read the handbooks prior to entering into the agreement? How many providers actually review it when changes are made? Our experience is that not many do so. Are you permitted to change your charge master, your charges as you'd like? Generally speaking, these contracts provide for annual review of your charge master, contain caps as to how much you can increase your charges. And then with respect to termination here, typically these contracts are for 1-year periods and are subject to what's called an evergreen clause, meaning they automatically renew unless terminated by either party. The catch here is the notice period to terminate. Sometimes the notice period is 180 days, meaning that you have to give 6 months notice just to terminate at the end of the contractual period. So let's suppose you entered one of these agreements on July 1st, 2014, and you decide in April of 2015 that you want to cancel it. Since you're less than 180 days from the anniversary date of July 1, you wouldn't be able to cancel it until July 1, 2016. In other words, on the following anniversary date. However, you should keep in mind that there can be shorter termination periods for certain networks that are specified in the contract. So the bottom line is if you're in one of these agreements and you're answering no to many of the questions above, you got to consider whether to cancel the contract. And similarly, if you're considering entering into one of these agreements and you're answering no to these questions and the reimbursement rates in particular aren't what they should be, you got to be very careful in making the decision to enter into these contracts. As you can see, in a lot of instances, these agreements hurt, not help your reimbursements. And properly managing this topic can really help you in terms of maximizing your reimbursements. So let me turn to the next slide and talk for a moment about, I'll call it a cousin of the third-party rental network agreement, which is the continuous discount agreement. This is another tactic used by the vendors for the insurance companies to lock you into reimbursement levels that are quite low. So the way these work is when you're signing a single case rate agreement on a negotiated case, there's a checkbox with language stating something to the effect of, by checking here, I agree to accept this level of reimbursement on claims in the future. Many providers don't even realize that they've entered into these agreements because oftentimes this box was checked by a staff member or even a temp years ago, and those personnel are no longer at the facility. And of course, because EOBs are difficult to read, many providers don't even realize these EOBs are referencing these agreements. They suffer from many of the same issues as third-party rental network agreements. For example, you're certainly not getting any steerage of patients from continuous discount agreements. The good news is that they're relatively easy to cancel, typically, with a modest notice period, and that way they're different from the third-party rental network agreements. we would encourage every provider to look at these agreements closely, make a determination as to whether to cancel them. And I cannot tell you how many times we start working with a customer who has these agreements that they don't even know about. So digging in and finding that out is an important thing you can do to get higher reimbursements on your out-of-network claims. Next slide, please. So let me wrap up with a few words about outsourcing. Remember, as we discussed before, that the nation's largest payers, who have considerable resources, expertise, and data, still outsource this function to companies that specialize in reducing out-of-network reimbursements. Yet despite the fact that the payers, even with all of that behind them, outsource this function, we talk to providers all the time who won't even consider doing so. So why should they consider it? So an analogy I like to make on this point is, as a former lawyer, I liken what providers are doing to hiring a lawyer. Since a lay person can file a lawsuit and represent themselves in the lawsuit against a large, powerful corporation, they can do that. But let's face it, a lay person doesn't understand the judicial system, doesn't know the law, doesn't know how to gather and present facts to support a legal argument, and doesn't know anything about the judges themselves. So while a lay person can, quote, do it themselves in court, is that really the best chance of being successful in that lawsuit? Similarly, does a lay person have the best chance of successfully dealing with out-of-network reimbursements? At a minimum, outsourcing should at least be something that you consider. Next slide, please. So what are the factors, what are the criteria to use when you think about outsourcing? Of course, compare how the firm fares against the 8 keys that we talked about before. Does the firm have the expertise, data, and resources? How do they charge for their services? Are fees success-based? Is there any upfront costs? How does implementation work? Is there software that's required? Are there minimums? Can you cancel at any time? And does it require exclusivity? We've actually seen some instances where companies require exclusivity with respect to handling appeals cases for surgery centers. Be very leery about entering into those agreements. If the company is good and they're performing, you should stay with them. But if they're not, you should have the ability to go a different direction. Next slide, please. So finally, just wrap up with a word about us. If you put us through the test and decide to work with us, what could you expect? You could expect an increase in payments from insurance companies, a reduction in the need to collect large balances for patients. As you know, collecting from patients is a difficult task, and getting more from the insurance company means less time chasing down patients. And then finally, many of our best customers really see us as an extension of their business office. And to be clear, we're not replacing your billing office, but by letting us focus on out-of-network bills, it frees up time for your staff to focus on their in-network Medicare and Medicaid accounts and increase revenue from those sources as well. Next slide, please. So in sum, I hope you have a better idea of the things you can do to increase your out-of-network reimbursements and realize the financial gains of doing so. As I said at the outset, proper out-of-network reimbursement management is one of the only ways you can improve your financial performance. Thank you for your time. I hope you found the session useful, and be happy to answer your questions. Laura?
Thank you, John, for this informative and enjoyable presentation. We will now begin with the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and we'll follow up on questions they did not have the opportunity to address. And I do have several questions here, so we'll get started. First off, John, I was wondering if you could address this question. It says, I have a multi-plan contract with the insurance company I'm with that's out of network with isn't accessing it. What do you do in that instance?
Okay, just to be clear, insurance companies are not required to access contracts. Typically what they're doing here is they are entering into a number of rental network agreements, and when a given claim comes in, they run it through their systems to identify which has the most favorable terms for a given case. And, as we talked about before, sometimes what they'll do is they'll actually give that case, rather than reimburse it at one of the contracted rates, they'll give it to one of their negotiation vendors in hopes that that vendor can negotiate a deal that's below the contract. So in other words, at the end of the day, there's really no good way to know how or when they'll access the contract, but you got to know going in that they may not access yours.
Absolutely. Okay, perfect. Secondly, why is it advantageous to generate at least some of my revenue from out-of-network patients?
The answer, I think, is simple, which is at the end of the day, out-of-network reimbursements are higher, and you're going to make money by having at least some of your business come from out-of-network patients. And providers really need to take advantage of that opportunity.
Absolutely. Thank you, John. The next question I have is, how can I determine if I'm getting a benefit from my third-party rental agreement?
Well, it's tough, because the only way you really know is if you're measuring the results on an EOB by EOB basis. Otherwise, it's difficult, and it's one of the things that make these agreements sort of difficult to deal with. Is providers don't know how their contracts are being accessed, and inquiries to their rental network account rep really isn't going to help you either. You really have to do a case-by-case, EOB by EOB analysis in order to track how you're doing on them.
Absolutely. Okay. The next question I have is, do the third-party rental contracts apply in situations where there's a fee schedule, such as with workers' comp or auto?
Yeah, they do generally include situations where there is a fee schedule, unless, of course, your specific contract excludes them. Basically, the insurance company wants them included because they want to have the flexibility of going whichever route they want to go to get the best possible deal on one of those types of cases. So, yeah, they generally are included.
Okay, thank you. The next question is, do I need prior authorization for out-of-network cases?
It really depends just on the benefit plan provisions, and those provisions apply whether it's an in-network or out-of-network patient. So in other words, if you need prior authorization when in-network, you're going to need it when out-of-network, and if you don't need it when you're in-network, you won't need it if out-of-network. So there's nothing special, if you will, about those prior authorizations.
Okay, perfect. The next question is, in these third-party network agreements, am I paid by the network?
No. In those, under those agreements, you're paid by the insurance company. It can add a level of complexity also here, because you're dealing with from a contract perspective, you're dealing with the third party, but from a payment perspective, you're getting paid by the insurance company, yet you have no direct relationship with that insurance company. So if there is a problem, frankly, it can be hard to get to the source, so to speak, with respect to payments, because of that sort of divergence, if you will, between who's paying and who you have the contract with. But yes, payment comes from the insurance company.
Okay, excellent. Next question. You mentioned earlier that insurance companies sometimes retain their vendors to try to beat the contracted rate. How can I find out if that's happening?
Yeah, you really have to dig deep, because when that occurs, a lot of times the vendors don't even know that there is a contract. In other words, what happens is the insurance companies will give the case over to the vendor and tell them they have to beat X amount in order for a deal to get done. So the vendors don't even know about the contract. So if you're dealing with the vendors, it's hard to find out that way. You really have to dig hard and make a lot of calls and contact a number of people to really find out if that's what's happening.
Absolutely. Okay. And then the next question is, I received faxes from these insurance company vendors asking me to negotiate a discount on cases, and my policy has been to throw those away. Is that a good approach?
No, that's not a good approach, and we do run into providers who say that they take that sort of approach here. The reality is, if you don't negotiate, the bill is going to be repriced, and when bills are repriced, oftentimes they're at much lower amount. You're better off negotiating, even if that means just accepting the proposal. And of course, here, we can get you much higher than that. But again, you should look to negotiate when possible. Generally speaking, that's going to get you more money in the door.
Okay. Perfect. And we have time for one more question. So this last question here is, I have cases where I'm out of network with the same insurance company with the same procedure, and yet I'm reimbursed at different amounts. How could that be?
The reason is that ultimately it's not the insurance company that drives the determination of what's reasonable and customary for a given bill. I mean, rather that decision is controlled at the group level, and they control the methodology to determine what's reasonable and customary. So you could have a given payer who's dealing with employer group A and dealing with employer group B, and they could make very different decisions in terms of how they want out-of-network treated. So I know that can be perplexing for the providers, but they need to understand that that's being done at the group level, not at the payer level.
Absolutely. Well, I want to thank John again for his excellent presentation, and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.